Hello everyone. In this video we will be learning about fungal infections. First let's begin with histoplasmosis. Let's see how histoplasmosis is caused. Histoplasmosis is caused by inhalation of dust-borne microcanidia of the dimorphic fungus Histoplasma capsulatum. Diagnostic patterns. Low inoculum exposure typically causes mild or asymptomatic pulmonary histoplasmosis. Higher inoculum exposure can lead to acute, self-limited illness with flu-like symptoms. Disease progression. Chronic pulmonary histoplasmosis develops on pre-existing lung abnormalities. 25 to 30% of patients experience progressive disease with potential complications.
Disseminated histoplasmosis occurs in high inoculum or immunocompromised patients. Clinical manifestations. Acute disseminated form in infants/children, fatal within 1 to 2 months if untreated. Adults typically experience milder, chronic form with periodic relapses. AIDS patients show acute disseminated disease similar to infant presentation. Diagnostic methods. Serologic testing is primary diagnostic approach. Tests include complement fixation, immunodiffusion, latex antigen agglutination. For AIDS patients, bone marrow biopsy and culture are most reliable, 90% positive. Molecular methods include DNA probe recognizing ribosomal DNA. Mycelial isolate identification possible through yeast form conversion or DNA probe. Histoplasmosis treatment summary. Patient groups. Asymptomatic or mildly ill, often no antifungal therapy needed, mild disease without immunosuppression, oral ketoconazole or IV amphotericin B. AIDS patients, intensive 12-week therapy plus lifelong suppressive treatment. AIDS patient treatment. Hospitalized, amphotericin B, non-hospitalized, itraconazole, 200 mg twice daily. Requires 12-week initial therapy plus ongoing maintenance. Key treatment principles. Monitor response via clinical, radiologic, and microbiologic improvements. Lifelong suppressive therapy recommended. Relapse rates without maintenance, 50 to 90% in AIDS patients. Maintenance strategy includes continued oral azoles or weekly bi-weekly amphotericin B. Prevents frequent infection recurrence. Next, blastomycosis. Blastomycosis. North American blastomycosis is a systemic fungal infection caused by Blastomyces dermatitis. Pulmonary disease probably occurs by inhalation canidia, which convert to the yeast forms in the lungs. It may be acute or chronic and can mimic infection with tuberculosis, pyogenic bacteria, other fungi, or malignancy. Blastomycosis can disseminate to virtually every other body organ, including skin, bones, and joints, or the genitourinary tract, without any evidence of pulmonary disease. Pathogen and transmission. Caused by Blastomyces dermatitis. Inhaled canidia convert to yeast in lungs. Can disseminate to multiple body organs. Clinical presentation. Acute, often asymptomatic or self-limited. Symptoms: fever, chills, productive cough. Chronic, low-grade fever, weight loss, night sweats. Can mimic tuberculosis or other infections. Diagnosis: direct microscopic visualization of yeast. Tissue biopsies. Culture of secretions. Treatment approach. Varies by patient's immune status and disease severity. Mild cases, potentially no treatment. Immunocompromised/progressive disease, required treatment. First line, itraconazole, 200 to 400 mg/day. CNS involvement, amphotericin B. HIV patients, amphotericin B induction plus oral azole maintenance. Moving on to Coccidioidomycosis. Coccidioidomycosis. Pathogen and transmission. Caused by Coccidioidomycosis. Endemic in southwestern U.S. semi-arid regions. Clinical presentation. Most infections asymptomatic. Symptoms: fever, cough, headache, fatigue. 25% experience valley fever with rash. Less than 1% develop disseminated infection. Diagnosis: positive skin test within 3 weeks. Antibody response: IgM peaks 2 to 3 weeks, IgG peaks 4 to 12 weeks. Culture of infected tissues/secretions. Treatment: only 5% of patients require therapy. Candidates: severe infection, high-risk groups. Antifungals: amphotericin B, initial therapy for progressive disease. Azoles, for subacute or chronic cases. Treatment duration: 3 to 6 months. Meningeal disease: fluconazole 400 to 1000 mg/day. Next is Cryptococcosis. Cryptococcosis. Pathogen: Cryptococcus neoformans, soil yeast. Non-contagious systemic infection. Clinical presentation: lung, cough, shortness of breath. Can disseminate to CNS and skin. Meningitis symptoms vary by patient type. Diagnosis: CSF examination reveals elevated pressure, lymphocyte pleocytosis, positive cryptococcal antigen. Detection methods: India ink smear, 60% positive. Culture, 96% positive. Treatment: asymptomatic cases, observation, symptomatic infection, fluconazole or amphotericin B. Meningitis treatment: amphotericin B plus flucytosine, 6 weeks. Alternative: amphotericin B, 2 weeks, plus fluconazole, 8 to 10 weeks. AIDS patients: initial, amphotericin B plus flucytosine. Consolidation: itraconazole or fluconazole. Lifelong fluconazole recommended. High relapse rate, 50%, in AIDS patients. On to the next, that is Candida infections. Candida infections. Pathogen: 8 clinically important Candida species, primarily acquired through GI tract or 4 catheters. Risk factors: immunosuppression, chronic diseases, medical interventions, catheters, multiple antibiotics, invasive procedures. Clinical presentations: 3 distinct disseminated C. albicans presentations. 1. Acute onset with fever/tachycardia. 2. Intermittent fevers. 3. Progressive deterioration. Diagnosis: limited diagnostic accuracy. Blood cultures positive in 25 to 45% of cases. Fluorescence in situ hybridization highly sensitive. Treatment: amphotericin B or fluconazole. Echinocandins effective for non-neutropenic patients. Remove central venous catheters when possible. Lipid-associated amphotericin B formulations recommended. Empiric IV amphotericin B for persistent neutropenic fever. And the last one is Aspergillus infections. Aspergillus infection summary. Pathogens: 3 key pathogenic species, A. fumigatus, A. flavus, A. niger. Acquired by inhaling airborne Candida. Types: 1. Superficial infection, managed with topical therapy. 2. Allergic bronchopulmonary, severe asthma-like symptoms. 3. Aspergilloma, fungal ball in abnormal sinus tissue. 4. Invasive aspergillosis, vascular invasion in immunocompromised hosts. Diagnosis: repeated culture and tissue microscopy. Radiographic findings: isolation from respiratory secretions. Treatment: primary, voriconasal. Alternative: amphotericin B. Caspofungin for refractory cases. Prophylactic therapy controversial. Key considerations: treatment depends on patient's immune status. Specific interventions for different manifestations. Varies from topical management to systemic antifungal therapy. And that was it for this video. Thank you.